where we go. So,
all right, so this is, we'll just do it quickly and we can break through it. We're not interested to move along or whatever. This is, I happen to have 3 talks here, might as well go through all of them. We're talking about Hispanics signing up today. This is a pointer? Yes. We're talking about Hispanics today in our outreach meeting. It turns out here are the demographics of the United States. That of the Hispanics, 64% are Mexican, 9% are Puerto Rican, but in Philadelphia, 57% are Puerto Rican, about 14% are Mexican. It's a little bit different. I think I talked about later on. The Cubans are mostly in Miami, Puerto Ricans mostly in New York, and it looks like Philly. Mexicans in Texas, Arizona, California. Dominicans mostly in New York. This is what we talked about already. Now, we have certain issues, that come up. There's Ashkenazi Jews tend to have, certain things. Blacks tend to have certain things, and usually Hispanics are really exactly clear on what our issues are. There's a low rate of heart failure amongst Mexicans, but but amongst Cubans, there's a high rate of heart failure, defined as not necessarily atherosclerotic heart disease, it's the primary pump issues, and it seems to be less prevalent among all Hispanics compared to whites. However, and then we even today we brought it up, and our hepatologist, who happens to be Paraguayan, said, "Oh, there's nothing that really is very unique to more prevalent Hispanics." It's not true. We happen to have more high rates of diabetes, obesity, the metabolic syndrome, which leads to end-stage renal disease, and also hypertension, which leads to renal disease, and cholesterol are similar to whites, but it's less well controlled, right? So what do you care, right? We care that if everybody has access to medical treatment, right, then they get their hypertension, cholesterol better treated. They're less costly to society, less costly to themselves. So it's important note. Also, these lesions are eminently avoidable in terms of lung cancer and screenable for colon, breast, and cervix are detected in later stages amongst Hispanics. Of course, that leads to, therefore, worse prognosis, more cost. Hepatitis C amongst Hispanics, they're more likely to be infected, less likely to complete treatment. In our Chamber of Commerce meeting, we had guesses. Maybe a person who's not legal, that was afraid to take time off from work. A person who's barely legal or barely scraping by, is afraid to take time off from work, so they're more likely to stop the treatment than to be depleted and then lose work.
Good evening, Harold. We're going through a series of presentations as long as we have the time, so just hang in there with us.
And amongst Hispanics, even if they try to get treated, it's less likely to successful treatment. They progress more quickly in fibrosis and cirrhosis. This is probably associated with more obesity and diabetes. We've learned in hepatitis C treatment, for hepatitis C treatment, obesity and diabetes are negative prognostic indicators for successful treatment for infantry. And I was in Texas for 4 years. So we learned, it's been established that there's a very high incidence of liver disease and liver cancer in the Rio Grande Valley. And overall, the state of Texas has the highest mortality in the U.S. So not only is it important to know the ethnic background, but also where they are, right? Like I said, there are different issues for each class, for each different ethnic group. We talked about this also in our meeting, where we said, okay, if we're going to outreach Hispanics, what's the use if none of them are insured, right? But we know that Puerto Ricans are more likely to be covered by Medicaid. Cubans tend to be well insured, but this is like a Miami, New York thing. And Mexicans tend not to be insured well. This is another issue, is that although 15% of the United States is Hispanic, only 3.2% of physicians are. I'm not sure if that includes Puerto Rico, which I just came back from. But the bottom line is if you have this disparity between physicians and patients, that leads to miscommunication. The common health issues aren't brought up. There's not a comfort level is not achieved. So hopefully we can fix that as well. So here's our organ transplant part. Overall, 104,000 people listed for transplant, and 7,000 die each year. Hispanics have increased 260%. However, they're not likely to donate, which stinks. And in LA, one trial in LA, there was presumably amongst Mexican Americans, that only 31% expressed their willingness to donate. So obviously, this is an important outreach potential opportunity, right, to get to other areas, other ethnic groups. In New York, the Hispanics donate at a higher rate than whites, probably secondary to LOLA, which is the Latin Organization for Liver Awareness, and they probably saw a lot of inroads into their organ donation rates. However, now LOLA is defunct. It stopped about a year and a half ago. So who knows? Hopefully that won't hurt New York donation. Here's the typical excuses for not donating, as I'm sure you've heard. This is not just limited to Hispanics. They believe that wealthy people are the ones who likely receive organs. Physicians won't work hard for the potential donor. It costs the patient. The brain dead person is not really brain dead. It's very confusing, right? He's breathing. There's a heart. The chest is going up and down on the machine. The heart monitor is going the electrocardiographic signals, and they're trying to tell them that their loved one is dead. It's hard to grasp a lot of time. And there's a lot of fear of body disfigurement, and you can't have an open casket. All those kind of typical myths, and it's cruel to the patient. We've heard that. And unfortunately, even recently, not amongst Hispanics, there's an imam close in this region who has blocked 3 donations at Einstein, and I think 1 or 2 at Penn, right? And he apparently acknowledges that it is not against Islam in any way, but he's kind of perpetuated these myths, which is a shame. So hopefully we can get the word out and see how lucky you all are, and hopefully get the word out and help others. So overall, we learned that donors are better educated amongst Hispanics, but mostly among everybody. And this is what you have to tell. You have to educate everybody, but this is what you have to tell all your friends. Make sure you have a discussion. In our organ procurement organization area, if you or your loved one sign your donor card and a member comes in and says they do not want your organs donated, the organ procurement organization respects the wishes of the family member who says no, right? So in Pittsburgh it does not happen, in Europe it doesn't happen, that's overridden, because it's written there that you should want to be a donor, but unfortunately here it can be overridden. They've lost 1 or 2 every few years that way, and as you know, 1 or 2 donors, that's 14 people's lives could be saved or enhanced. So 28 people every year to get hurt by a family overriding that. So very important to state this clearly to the locals.
Just out of curiosity, as a physician who depends upon the donations, how do you feel about that? I mean, the laws of all 3 states say that you have the right, you the deceased.
Yes.
So are they doing something illegal?
No, but what happens is so much of this is based on the previous slide, which is feeling and that kind of stuff. So if you're already in a situation where they feel you're not going to work as hard on the donor, that it's going to organ.
Right. But what I'm saying is you have the legal right to designate your organ for donation. Okay? And now all of a sudden somebody who does not have the legal right gets to override your legal right.
Correct.
How is that legal, is what I'm asking.
It's not legal, it's something that nobody wants to...
So it's illegal.
Yeah, nobody wants to fight it, right? Nobody wants to fight that because if something happens, right, something happens and then the family goes to the press and says they took the organs away and all that stuff, that negative publicity might lead to 15 less donors in the next year.
So why are they doing it the other way in Pittsburgh and other places like you said?
They believe that they believe at a certain time you have to put your foot in the sand, maybe take the penalty, foot in the ground, maybe take the penalty now, but overall it would be better in a few years, right? And this OPO is looking into that. So in general, this is relatively new. My partner, whose pictures on the thing, he knows that we treat Hispanics, their results and their immunosuppressive needs are somewhere between whites and blacks. It's not really true in terms of immunosuppression needs and results after transplant. Asians do best, right? And then Hispanics, then whites, then blacks, for a number of different reasons.
Such as?
Well, the Asians seem to have, I'll go from African Americans. African Americans, you have the socioeconomic issues of not being able to pay for the meds and all that stuff. The educational issues as well. And then you have the actual, probably biochemical issues where African Americans don't metabolize. Everybody heard of Prograf? Don't metabolize Prograf and cyclosporin the same way as whites. So it has been studied in VA patients amongst, with African Americans, not so everybody's getting their meds, everybody's having the same follow-up, also African Americans still do worse, right? So if you, so that has led to overall kidney transplant, half-life of a kidney in African Americans is only 6 years, whereas in whites, 12 years, yours live longer, and things like that. So that's one of the things. We think there's some genetic predispositions that we're not fully finding. We're starting to get uncovered now amongst Asians that allow it to be easier for them to receive organs than they're not as sensitized. It's a kind of using that word broadly, sensitized to organ transplant.
What about donation from Asians?
Yes. So I don't know about Asians, but the donations from blacks to whites, those organs do not do as well as whites to whites, right? We've also learned that females to males generally don't do as well either, right? Now, males to females, there's two competing interests. So if you have a big kidney, from a male to a female, the bigness of the kidney is thought to be a good thing, with more nephrons, more kidney working cells. However, the genetic antagonisms are pretty high. But for the most part, a big man to a small female is good. A small man to a small female is not as good as a female to a female, right? But none of these are big enough that we say, oh no, I wouldn't accept that organ, that kind of thing. In kidney transplant, Hispanics have excellent comparative outcomes, we stated. There used to be, there still is a small disparity between patients on the wait list and actual transplantation rates, and there's a high rate of diabetes after transplantation. For liver transplant, there's superior outcomes compared to whites, but less access to liver transplantation compared to whites. Right? Who knows? That's been we've always, as transplant community, we've always prided ourselves, at least on once we see them, patients or minorities or lower socioeconomic groups, that once you see them, time from seeing to transplantation is the same, right? And traditionally the roadblock was out in the community. That's still there, but it's hopefully improving, and hopefully we're improving our work. Here's heart transplant. Here's the heart transplant. Excellent survival when compared by race and ethnicity, and better access to transplant. So basically, for all this thing, what do we need for Hispanics, for any underrepresented member of society, family discussions about donation, everyone has to have insurance, jobs, responsibility.
Now, just backing up for a second there, that was kind of interesting. For livers, there's less access for Hispanics to liver transplantation, but hearts, they have easier access. Why would there be a difference? I mean, anything I can think of would seem to apply to all transplants without knowing.
Not sure. I don't know, something like, as what just popped in my head, was hearts, maybe people are younger, right? And they're younger and they don't have that whole coming out of the drug abuse, alcohol abuse thing in the past. Okay. Maybe they're getting younger. So maybe you divide it up by diagnosis might be a different animal. Some Hispanic woman who has primary biliary cirrhosis, autoimmune hepatitis seen relatively early might get better or earlier access than a 55-year-old Hispanic male, alcohol, former drug abuse, maybe. Yeah. And maybe the heart is the same thing. That's not they're in the system already. From always having a bad heart, always in the medical system, always having a cardiologist. But that's purely conjecture.
Yeah. Okay.
I have a question. You mentioned earlier about communication problems, and you say only 3.2% of physicians are Hispanic.
Right.
But do you accept the numbers of Hispanic-speaking, say, doctors and nurses? Is that number similarly low, or is it?
I don't know the exact number. I don't know the exact number. There's two issues. One is the language speaking of facility, also the culture of that comfort level as well. So if you're an American who speaks Spanish, right, are you also good culturally, right? And if you're a Hispanic whose Spanish is not so hot, is that enough, culturally?
So you're saying patients will trust an American doctor less if they speak Spanish, or to say somebody who's their own nationality?
Yeah, I think that's a vague generalization. Right?
Yeah,
but yeah. I mean, even I'm Colombian, right? So I can see the Colombian patients. I can where we can spot. You know, as soon as they found I'm Colombian, and so,
Right.
you know, and then my partner, he's Salvadoran, so we don't have any Salvadoran patients. But when we do, but I don't know, it's hard to say, shut this off, I'm just conjecturing. But, so I see the Colombian patients, they kind of gravitate towards me, it's a vague generalization. But then my partner speaks Spanish very, very well, right? So then they would kind of also gravitate towards him because his Spanish is better than my Spanish. You know what I mean? So it's kind of convoluted. But it's clearly is been documented many times over in the literature that the language and the culture is clearly a barrier to appropriate care, right? We discussed this in our radio interview. The patients come in, they tend to say, you know, how are you doing? And they've been waiting for 3 months to see a doctor. Yes, sir, everything fine. And they leave. And that's probably, that's not just Hispanics, that's a Korean coming to an American, that's a Chinese coming to American. So yes, sir, and they leave. It turns out they did have a list of problems they just felt uncomfortable, saying.
Let us have Harold introduce himself. Harold will get our name, where we got transplanted and when, and what type.
I got a kidney at Hub from my wife in 1999.
Awesome.
Okay, and which talk did you want next?
This is a liver transplant one.
Okay.
Oh, it says OLTX.
Gotcha.
For you, this is for you. Okay. This one's for you. I feel bad the other ones are so, this last one's just so general. Plus I'm giving this Friday to our colleagues. All right, so here are the indications for liver transplantation, most commonly hepatitis C. Here is a normal appearing liver, the left lateral segment, the right lobe, it belongs up here, and when the person gets cirrhosis, they get this nodular development on the liver, and then with jaundiced skin. Here are some indications for transplantation. So this is ascites build up, you get a umbilical hernia, and ascites builds up, and then that fluid is infected, and that's so we don't do liver transplants for every cirrhotic. We do liver transplantation for patients who have decompensated cirrhosis. So it manifests in development of ascites, which is infected, encephalopathy, which makes you confused, which means confusion essentially, due to the liver not detoxifying the toxins in the body, and sometimes they can't even breathe on their own. Another type of decomposition is development of a liver cancer, which is that. And here are esophageal varices. These are vessels that are involuted when we were born, but once the liver gets damaged, they get recanalized and they get thin and they can bleed. Here are the complications. So organs are allocated by what's called the MEL score. So this is good from the other talk. It stands for Model for End-Stage Liver Disease, and what it is a objective score measuring the creatinine, which is kidney function. The total bilirubin is what makes you yellow or green, and the INR, which is the international normalized ratio, which tells us how quickly our blood clots. It's a complex formula, and it was created in it was put into effect in February 2002. Right. The reason why is because our previous scoring system was based on the child score, and the location of the patient. Right. So and that part of that was very subjective. You had to write, patient had ascites, and you wrote yes, really bad. Right. Was he confused? Really, really confused. Right. And then you have patients who were in the intensive care unit, right, who might not have deserved to be there, or who knows, it's controversial. People were advocating for their patients, trying to do the best thing. This took out that subjectivity and made it totally objective.
Let me interrupt you just 1 second. Carl Anderson and his wife. Carl, as you're going around for the last 2 seats over there, why don't you introduce both of you by name, where you got your transplant, when you got your transplant, what transplant you got.
Okay. On your way, I'm Carl Anderson, also known as Papa Carl, if you listen to music. This is my wife Jean, who's a nurse, and I was transplanted on September 17th, 2004 at Hull.
What organ?
Liver and a kidney from a single donor.
Awesome. That's one of the gratifying things about transplantation is that most of the time everybody remembers the day they get transplanted, like their second birthday. Things like that. It's very gratifying. Whereas, you talk to somebody, when do you have your kidneys taken? I was a kid, I was 15. Like, when you liver, oh, June 13th. That's very gratifying. Anyway, so we're just talking, this is general liver transplant talk, the other one's even more general. So this is how livers get allocated. So if you have liver and kidney disease, liver and kidney failure, your MELD score is automatically about 22, right? And then you have, so that's automatically there. And also if you're on dialysis, you get certain points. So this MELD score was developed by Richard Freeman, who's now in Dartmouth, either Dartmouth or Vermont, and it was originally used to determine the mortality rate before a TIPS procedure. It's a shunt procedure we do as a bridge to transplantation, and then it was shown to be pretty accurate in terms of overall pre-transplant mortality, and then it's a little bit less accurate for post-transplant mortality, meaning that we know these people are going to die early, so they get allocated livers earlier. It does not necessarily translate to how they will do afterwards. And what this has done since 2002 is that it's allowed us to transplant sicker patients, reduce the waiting times, have overall the same outcomes, but less registers because we're not listing those people just to list them, just to gain time. We're not gaming the system, all that stuff.
What are the numbers like?
What do you mean?
20, 25?
Here it is. So the MELD score can go up to 40, but it's capped at 40. So MELD score go to a gazillion, go to 50 or 60, right? I guess 50 is probably the highest. But it's capped at 40, right? And this is also important, I guess, for allocation. So you have this MELD capped at 40, and then that's the highest. And then you have status 1s, which are higher, right? Because that's how somebody comes in with acute liver failure. They mentioned that. And that's somebody who does not have established liver disease. They suddenly develop acute liver failure, and those people are the top of the list. Mushroom poisoning, Tylenol overdose, those kind of things.
Where are you transplanting now?
What numbers? I'll get into that. Okay. So we've learned with the MELD score that if your MELD is less than 15, right, it's not appropriate to be transplanted. Meaning the risks of transplant outweigh its benefits, infection, rejection, bleeding, increased cancer risk, perioperative death, bleeding, yada yada. So that's not appropriate. And so what happened was before the MELD score, it turns out about 15 to 20% of patients were being transplanted with MELDs less than 15. Right? Not because everybody was a jerk or an idiot. We just thought we were doing the right thing. Somebody had ascites, oh, that must be an indication. Somebody had bad itching, bad fatigue, those things, we thought that was the right thing to do. So we've learned since then. So greater than 15 means you should be transplanted. Without transplant, you have a 2% 1 month mortality, right? Between 21 and 30, 40%, 4.0% 1 month mortality, and greater than 30, 20% 1 month mortality. For overall in this organ procurement area, it would appear that depending on your blood type, if you're blood group AB, you get transplanted around 24, 25. If you're blood group B, you get transplanted around 26. If you're blood group A, around 32, and blood group O around 38 or 40. So it's gotten really bad. It's gotten worse. The number of donors are down a few years in a row from Gift of Life. And Gift of Life is the best performing organ procurement organization in the United States. Yet their numbers are down 2 years in a row, at least. And because of that, we're transplanting at higher rates, higher MELD scores, which means sicker going in, which means they're sicker going out, which means there are more patients not living, more patients struggling, staying in the ICU, and all that stuff. So if we have more donors, more people get transplanted, and they would be dying or doing very poorly after transplant. So the MELD score captures, I think it's 78%, either 78 or 83%. The MELD score is accurately depicts how sick you are, where you should be. Sometimes you miss things. It's not captured in those 3 lab values. Exemptions. So exemptions, what we do is we have these established exemptions. Hepatocellular carcinoma, biliary strictures, infections, a lot of bleeding, ascites. Another one is called hepatopulmonary syndrome, where your liver disease is so bad it causes your oxygenation to be poor. Those are exemptions. So we do is we write a letter. We write a letter asking for points, right? We have a review committee, and then we'll vote on whether that's appropriate or not. For the most part, these are standard ones, and then every once in a while there are kind of non-standard ones if we ask for. Here's a tumor. The tumor has to be. Here's a tumor, right? The tumor has to be within this certain size constraints, it's called a T2, so between 2 and 5 centimeters, or 2 or 3 nodules, all less than 3 centimeters, and they're initially given 22 points, and that increases every 3 months. This is called the Milan criteria. What happened was, in the beginning, like in Starzl's day in Pittsburgh, they were transplanting everybody with hepatocellular carcinoma, and everybody was dying. They were getting recurrences, things like that. So this guy Mazzaferro in Milan came up with he looked at the results, and he found that people who had tumors less than this size or less, that they did well. So it's called the Milan criteria. So that's become accepted criteria for transplantation. Now, we've found in certain areas, like in Texas and California, they use the UCSF criteria, which is up to 6.5 centimeters of tumor size, and they accept more nodules.
Susan, got a question?
Yeah, just out of curiosity, do you know where Steve Jobs fell into tumor size?
Steve Jobs was a neuroendocrine tumor, right, I believe. Am I allowed to talk about it in public?
Sure.
Yeah, because it's common knowledge, right? Yeah, my impression is that he was a neuroendocrine tumor, which is that's a tumor that you usually get in the pancreas, right? Or somewhere after the pancreas, and it spreads to the liver, and then encases the liver, needs to be transplanted. So he probably did not have a high MELD score. He was probably exempted. You know, like exemption points. And that brings up another issue, I guess, is unfairness, right? So the MELD score was brought up to make everything objective, right? And then so the first permutation of the MELD score of the hepatocellular carcinoma HCC exemption was almost every tumor, almost everything we thought was a tumor got exempted. And then they made this rule that had to be at least 2 centimeters in size, right? So now it is kind of a movement afoot that to give tumor patients less exemption, less weight, would appear that they're being overly favored.
But when you say they're exempt, they're not exempt from the transplant, they're exempt from the MELD criteria.
Right, they get exemption points, right? What happens is their MELD score is low, right, because their lymph labs are okay, but they're going to die at a rate. Some other reason when they spread, that kind of stuff. So now they have 22 points and it goes up every 3 years. Now it's being proposed that perhaps they shouldn't get 22 points, maybe they should get 15 points and move up more slowly, right, because they've been unfairly benefited, right? But that also, so talking about people who are unfairly benefited or unfairness is also significant geographic disparities, right? So in certain areas you get transplanted earlier.
Yeah, that's a different issue.
Right, which is a different issue, but everything's related, right? Because if you say, you're talking disparity and then with HCC or not, then the next one raises saying, well, what about geographic disparity, which are much worse? That brings up all these other issues. And then that brings up to, okay, are you going to reward, some people argue, should you reward a low-performing organ procurement organization with organs from a high-performing organization? In other words, so if you're poor and should get an organ, and then just say Iowa's got a great donation rate, should Iowa be sending livers to blank city that has a poor one? You know, that kind of thing. And that's one of our issues. That's what's, an issue constantly being brought up. And the bottom line is, if we're just spreading the word, is that we're all trying to do our best to try to make it fair and equitable for everybody.
Doctor, you're going to talk about how these rules come about, the UNOS rules and the UNOS committees that weigh in the simulations, or is that something you're going to get to?
Not really, but
Okay. Well, I just want to bring out then, if I may, these numbers are things that are calculated and come up over time with UNOS committees of experts who sit there and look at simulations of historical data of people who receive transplants. And so they change these rules and say, well, if this was a rule, what would have happened? How many would have died before? How many after, et cetera? And they come up with, as he's talking about, different permeations of these which have a better outcome. And so then it goes through all sorts of reviews, out for public comment. You have all sorts of input going into this. And finally, it could take years for some of these rules to change. And what you're talking about here with the MELD score is something that in 2002 has been modified several times by the liver committee. There's committees for each organ allocation area. And there's patient affairs committees that look at it from the patient standpoint. There's all sorts of committees. I think there's about 22 of them.
For the geographic changes of this geographic distribution, what would happen, what wouldn't happen,
Right.
all that stuff. So I think this is commendable that we need to try to come up with a system that's always objective, always fair for everybody. Hi.
Introduce yourself, your name, where you got your transplant, and when you got it.
My name is Nancy Woodson. I had 2 kidney transplants, one in Temple and one at Christiana Care Hospital. And
How long ago?
first one was 16 years ago, most recent was 2007.
Well,
Thank you.
I'm just going to overall, generally talk about liver transplant when we're waiting.
Oh, okay.
And we're basically hitting everything as we go along. So everybody's educated. We're hoping that, since everybody is a recipient, that you can go and spread the word to other potential donor families and things like that, and just kind of educate on that so we can educate them. So here's a liver tumor that's big, right? So what happens, we do different things to it. So because there are 10% of the lists are dying, and the liver transplant lists are dying every year, there's a tumor spread, makes them untransplantable. We do different, we call them local regional treatments in order to downstage, either downstage a tumor into Milan criteria, or what we hope is to slow down the growth and minimize the chance of metastasis while they wait, right? In the perfect world, as soon as you get diagnosed, you can transplant them. Unfortunately, that does not happen. So one of this is called chemoembolization, one of these local regional treatments, and they go through usually through the femoral artery, feed up through the hepatic artery, and then they inject chemotherapy into here. We at Einstein do this, obviously, but we also do alcohol infusion, acetic acid infusion, and these yttrium beads, these radiation beads, we put them right into the tumor to destroy them. Here's also, we also do this. We do cryotherapy, which means freezing, or radiofrequency ablation, which means burning. We either do this laparoscopically, or we do it with radiologists. And basically, it's a probe going in, and either freezes the tumor till it's dead, or it heats the tumor until it's dead. Here's a tumor that's dead. Here's a cirrhotic liver. This is where these livers all belong, right in the bucket. Right? Unfortunately, except we need more donors. I briefly touched on pulmonary liver failure. It's defined as coagulopathy, which means the inability to clot properly. So an INR, that number I said before, twice normal at least. Jaundice, confusion, without prior history of liver disease. In order to be listed as status 1, they have to be in the unit. This is another example of appropriate regulation. So you can't do any shenanigans. You can't say, oh, this guy he's fine, he's walking around getting a liver. Got to be in the unit. He's got to have abnormal laboratory values. Those kind of things. So everything's up and above board. Here's what we do for all organ transplant recipients. You guys all have these stress tests and pulmonary clearance and all that stuff. Make sure everybody's can pay for their meds, are in a stable living situation, can get to clinic. These are obviously everything in transplantation is always a donor issue, right? So because of that, we've been more aggressive using donors, right? So here's donors that are already cirrhotic or bad scarring, or have tumors that are bad to use. Very fatty livers, and that's been a problem, right? As our society ages and gets fatter, there can be more people who need livers, right? It's called non-alcoholic steatohepatitis, NASH, right? That's going to take over. Remember I said before, hepatitis C was the most common indication. In about 2020, NASH will be the most common indication for transplantation. And unfortunately, if we have more recipients who need it for NASH, there will be more donors out there whose livers are too fatty.
Can I take you back just for a minute? When we were talking about recipients and qualifying, how does alcoholic abuse play into qualifying to be a recipient, and how does your program treat that?
Right, so what we usually need 6 months sobriety, right? And my partner in Texas came up with one of the early papers on defining patients who are likely to do well after liver transplantation. So usually it's 6 months, at least 3 to 6 months. Usually it's somebody with a good spouse or significant other, somebody who's not lost the job, right? And somebody has, or friends, and somebody has gone through a rehab, or at least Alcoholics Anonymous. There's other things. So my brother's a cardiologist, and he said, oh, you transplanting drunks? Like, and that's an important thing for everybody to say, because everybody learn, because if that might be one of the reasons why would I want to donate my loved one's liver, so I go to some drinker who's still drinking, right? are using these criteria, and insurance carriers also hold us to this, right? The rate of recidivism after liver transplantation is about 3%, 4%. So another way to look at it, the rate of recurrent disease, because alcoholism is disease, is lower than for any other indications, such as autoimmune disease, hepatitis C, which is a very bad recurrence issue. Right? So overall, when you look at the disease process, we're into second and third chances. We are not stupid because we realize that if we just transplant every alcoholic, there's going to be a horrible wastage of a precious resource. So we hope we screen them properly and do right by them.
But these are individual program guidelines as opposed to anything nationally, with the exception of insurance.
The program guidelines tend to be similar everywhere, the same everywhere. Yes, sir.
I'm a licensed clinical alcohol and drug counselor. In 6 months of sobriety in the DSM-4 is partial remission.
Right.
1 year is full remission. So by going by the standards that are set up in a DSM-4 that are used in behavioral health care by physicians and other practitioners, this is right in line with best practice.
Right. So here's an ideal donor. We have less of these now, right? Now our population is aging. There's hepatitis C out there and other things out there. The issue is here, our organ procurement agency is one of the world's leaders in donors after cardiac death, right? So in the world and in the nation, usually about 97% of donors are donors, they're brain dead. Those are donors, the brain is dead, the heart's still beating, and there's oxygen going to the organs, blood going to the organs, all those things. There are some patients who do not meet brain death criteria, however, their prognosis is so poor that the family wants to donate, right? So these patients are generally taken to the operating room. The artificial means of support that were going to be removed anyway are removed. The patient sometimes extubated. Person passes away. We have to wait 5 minutes for legal reasons, right? And then we quickly get the organ. We can make the incision with the organs. The first heart transplant was done that way, right? And that's how they were done in the old days. And that's why our results weren't as good. Because during that time, when the person's dying, right? And when the person has to wait another 5 minutes and they have to wait to get the organs out, right? That's low blood flow, low oxygen, to the organs. So although they are good in kidneys, they are probably as good long-term as brain dead. Livers, the results are a little bit worse. Hearts are used but scary. Lungs used but scary. That kind of stuff. So that is something that this organ procurement organization is very good at trying to capitalize on every donor, right? But in a perfect world, it would be best if the donor family could allow the patient to progress to brain death. Probably get more organs per donor, help more people. So here we talk about the downside of waiting, right? Here's 2,000 patients die every year waiting for this kind of perfect donor that's really out there. Here there's 17,000 people on the list, only 13,000 donors out there a year. This is dropping a little bit, around 7,000 transplants a year. Here are examples of extended donors that we use. So here's a fatty liver, right? It's like pate, right? It's pate, that yellowy kind of stuff, and that's how you make pate by forcing a goose's mouth open and feeding him, right? Is this on a timer? Are you on a timer there? Okay. So anyway, so here's what it looks grossly, and then here's what it looks under the microscope. These are fat globules that have kind of taken over the liver. And as I mentioned before, those fat globules take over the liver also don't allow for hepatitis C treatment to be successful. Right? So we use up to 30% fatty livers, and it's called microvesicular. These are small fat globules. We can use more of that. And we're hoping that if we can transplant these livers quicker and use more biopsies, then we can transplant more of them. Here are older donors. Unfortunately, it's been found that they're associated with more vicious, virulent hepatitis C recurrence. So it's not great. I guess this is making me go fast. Oops. All right. Obese donors also associated with fatty livers, but we can use half of them, probably successfully. There's a counter in there. There's a thing there that says how fast you want to go and all that stuff. Pediatric donors, once again, slightly more risky than standard donors, higher risk of hepatic artery thrombosis. This is donor after cardiac death, I mentioned before. His hepatitis B organs. Generally, we can use a hepatitis B positive organ for somebody who had hepatitis B cirrhosis. We can use a hepatitis B organ for somebody who has established immunity to hepatitis B. That's all organs for the most part. And unfortunately, sometimes now we are compelled to use hepatitis B organs even in people who do not have hepatitis B immunity or disease because they're dying at such a high rate. And hepatitis B is not treatable, right? So we've done that 3 times in the last year at Einstein, right? The option is death or 2 extra pills, right? So we decided that we've gone for the 2 extra pills. What's that one? Here's a combination of both at UCLA can be used. Here's infections. We're learning more and more what we can use. Donors that have infections in their bloodstream, infections from their brain, fungal infections, these things can all be used. This is HTLV, which might be a marker for a particular type of blood cancer. We don't even check it anymore because it looks like it does not transmit. And these are the ones that are bad. HIV has been transmitted and bad results. Rabies, West Nile, all these things have been transmitted and with bad results. Usually, if you can use a person with a history of skin cancer, or a person or a donor who had a history of disease that probably was treated and probably cured, there are certain no-fly zones, like melanoma, you never want to use that one. Certain types of brain tumors you may not want to use, although this is something that we're revisiting. There was a recent study out of Italy that showed that you might be able to use this. The bottom line is we're always expanding, always trying to do what we're forced to. There's just not enough donors out there. Here's and also just a recent paper from Morris in 2010 from Italy. Basically, they've established a different protocol for the genitourinary malignancies. It turns out it's probably safer to use than previously thought. And we've used donors who had a kidney cancer on one side and used the other kidney, or had a kidney cancer on one side and used the liver. We use that about 4 or 5 times. Here's a donor, picture of a donor, artist rendering of a donor we used, and we transplanted that person, just sewed it up on that paper. A lot of people would have turned that down. This is us. This is HELP syndrome, which is what people who are women who are pregnant, they get like a preeclampsia type thing, and the liver goes into failure. And so we had a donor who she had this happen. She had a stroke and died, and she donated the liver. Family donated the liver, and we used that liver. So sometimes this HELP syndrome is sometimes an indication for transplantation, right? But hers got better, right? But unfortunately, she did not. We were able to use that liver. We also, here's people reusing organs, right? In other words, first of all, reusing organs, but also a heart and kidney recipient using donating a liver. All these successful liver donors, even though they donated other parts, they were recipients of other parts of their organs. This is a paper we wrote about a few cases where the donor had been a liver recipient in the past. We reused the liver, and then we wrote up the results in the United States and published that in 2004.
Now, just out of curiosity, is that reusing a liver immediately after a failed transplant, or?
So that's a good question. So the most common scenario is fulminant liver failure, right? The person comes with fulminant liver failure, they're intubated, they're sick, right? You do the transplant, and it turns out they're brain dead, right? That they're not alive. So there's that liver, you just put in somebody that we reuse, and that's the most common scenario. In one of ours, we later had a stroke afterwards, and we reused it shortly thereafter. And another case, this person had a stroke a few days later. There are a few cases, and one recently written, about 10 years later, reusing it.
Oh.
And we went to Wills shortly after I wrote this paper to try to do a pancreas procurement in a patient with a liver donor. And the whole thing was great, but then there was a fear that one of the lymph nodes was positive for disease. We didn't use it, and unfortunately, it turns out that lymph node was okay, it was normal. Everyone was afraid to call it at 2 o'clock in the morning. And that's one of the things that we deal with, right? Because if we have government oversight, medical, legal stuff, so it's always, and then what's right for the patient, it hurt the patient, all those things, so that kind of stuff is pretty scary for everybody involved. So we have to make sure we're trying to do the best for the patients, but also protecting everybody involved. Here's the high sodium levels might be associated with bad results or might not be associated with bad results. There's different poisons that people die of these poisons, yet we've used the livers afterwards. This is Johnny Mon in New York Presby. Wrote a paper about livers that nobody else wanted, and they used it and they had good results. This is, I'm blanking on his name. This is Prometheus, right? Who was a gay fireman, and he was condemned to have his liver chewed at by I guess a vulture. Apparently, why can you do that? Because those livers grow back, right? So you can do, therefore we can use split livers, right? Divide the liver to two. There's 2 different recipients. There's a live donor you can do all that stuff because they grow back. I got rid of that one. Right, so here's what might be in our future is pig organs, right? Theoretically, genetically alter them so they can be a donor. The big problem, one of the big problems is PERV, is a prehistoric, some kind of E retrovirus, whatever E stands for, I'm blanking on it. These might be viruses that might be uncovered, right? After transplantation, might spread a worldwide epidemic. We don't know that. We don't know if it's safe or not. Hello. Yeah. Can you call me back in 5 minutes? Okay. So what mostly happens is they use for. Here's your donor thing, right? To make sure that you're telling the world. Here's some quick pictures of liver transplants. This is the hepatic artery being sewn in. This is a bypass pump people frequently use. This ultrasounds we usually get. You probably get a bunch of ultrasounds right after transplant. Some complications of the portal vein being clouded off. Hepatitis C can come back. These are different aberrant complex artery anatomy that we have to use, and we can't throw these organs away. Here's the portal vein being connected, being anastomosis. Oh, that's why. Because this is not my edited version. Sorry. There's a liver up there. Beautiful new liver.
It's like dinner.
Right. Yeah. Small intestine, momentum. Here's the suprahepatic vena cava being sewn to the recipient's inferior vena cava. There's the liver back there. You're being sewn again. So you're being sewn. That's what we just call the modified piggyback technique. That's what we do. Oh, that's the portal vein. Portal vein. Hepatic artery. Portal vein. Hepatic artery. Here's the artery rendering. So when you do you put a clamp up here, you sew the liver up here. That's the hepatic vein, and that's what I was talking about. Here's the other hepatic, the other inferior vena cava anastomosis, and then the portal vein anastomosis, the common bile duct anastomosis, and the hepatic artery anastomosis. Sometimes the bile duct isn't good to connect it right away, so we use a T-tube, so we can, some people use it anyway, so we can look at the bile output, or we connect the bile duct to a liver intestine, and either we do this kind of drain or not. Here's a baby with ascites. Most common indication for transplantation in babies is biliary atresia, meaning the bile ducts don't form properly. Here's a liver that's been divided. Right, so one goes to the larger side goes to the adult, the smaller side goes to the child. These are usually the smaller side going to the child, or the various complex connections and stuff. Here's the adult side, the right lobe, usually going to the adult. We've had some We've shared one liver like that when I was here before, in 2002 with Penn. And they took the left, we did the right. Here's the kind of another artery revenue I said before, the hepatic veins, bile duct, T2, inferior vena cava, portal vein, hepatic artery. Here's that blue limb we discussed, that intestinal limb, the bile duct's not there. These are complications, you want to know about these.
Talk to us just briefly about the allocation process when you're splitting the liver. For example, you're on the list, you come up as having the patient that's at the top of the list for a liver.
Right.
At what point is the decision about splitting the liver come up, and how does whichever portion get reallocated?
Very contentious issue amongst transplanters, because you have the adult guys versus the pediatric guys, right? And what we all agree on is that the pediatrics take precedence, right? So usually they're out, so we have these, we have all these MELD scores, but if you have a PELD score, which is a pediatric end-stage liver disease score, if they're higher, they take precedence, they get over an adult. So if a very ideal donor comes up, the pediatric center has the opportunity to split that liver, right? And then they offer the adult, the right side remaining, to the highest adult on the list, right? So that's usually how it works. And there's some issues because you're sharing blood supply and things like that. There's some issues in what's the appropriate way to divide and things like that. So that's the subject of many committee meetings. But usually it's pediatrics first and adults.
Are you going to get another phone call in 5 minutes? You want to take care of that in between these presentations?
Sure.
You want to step outside, there's a booth out there, and we'll have a private conversation. CJ, why don't you talk a little bit about it? We haven't had an author in here. CJ and I had a conversation, he was out there looking for some information about a book he's writing, a novel. Why don't you talk about what you're thinking of and share with the group?
Sure. So first of all, I'm a journalist by trade. That's my full-time job. But I'm working on my first book, and it's actually going to be a novel, and it's going to involve heart transplantation. My book is the main character is that will have a heart transplant, and that's kind of what the book will be about, and go from there. So me obviously not having a transplant, no transplants in my family. I don't have any immediate knowledge about what's involved with that. So I've been just starting research, reading books, and reaching out to people in the local community to find out more information about this. So that's how I got in touch with Jim. I found out about the Second Chance Support Group and about most, and hoping to find out more information, and as well being able to speak with people locally elsewhere who have had heart transplants and kind of talk about their experiences, what they went through, and use it as a good solid footing for my book. But again,
So what got you?
Yeah, I was going to say, where did you get the interest since you don't have a personal
interest? It's never been a major, it's been like no childhood fascination or anything like that. My parents are in the health field, they're chiropractors, but specifically they have a book, The Heart's Code, which I'm not sure, and I know Jim's read it, but I don't know how many else you've had read. And before I even read it, I just had this thought of an idea of a person who had a heart transplant and experienced memories from their donor based on that transplant. And obviously reading The Heart's Code and learning about cellular memory, it seems to be, if not a widely accepted medical phenomenon, something that anecdotally has been talked about. So that's where my interest lies, and that's how I come up with it.
Do you have a title chosen yet, so we can keep an eye out for it?
Not yet.
All right, well, when you do, you're going to pass it on the titles, we can share it with our audiences, and, we probably all want autographed copies, wouldn't we? Well, depends on how good the book is. Free autograph. Dr. We were just investigating our author over here, see why he was writing a book that involved a novel with a heart transplant to fill in for you, so.
The only one I know about is blood work, right? Blood work involved involved a heart transplant. And Clinton's was involved. So it's kind of covered mostly. This is basically what's new and hot on the allocation side, on the transplant side. Maybe some obvious levels you guys remember that you went through this. There might be a reminder to you also because hopefully educate others who are on their way to get organs. So in order to be listed for a kidney transplant, your glomerular filtration rate should be less than 20. That means not necessarily on dialysis, but just that means that your kidney function is failing so badly that the belief is need to be transplanted soon. Or alternatively, once it gets lower, a certain point, lower than 10 or 12 usually, you become dialysis dependent, and you have to be a good candidate, as we discussed before, psychosocially cleared, good heart, a lot of times lung clearance, at least normal chest X-ray. For all of our clearances, we kind of evolved as there's not evidence-based guidelines for doing the appropriate thing. So if a 28-year-old woman walks in, maybe in the 80s, we would not a mammogram on her. Why not, right? But now we do things that are the appropriate guidelines that have been established. So older than 50, you need your prostate examined in the PSA, you need colonoscopy, your mammography, age greater than 40, your pap smear for appropriate indications. So as I said before, liver transplant is reserved for patients who have decompensated cirrhosis, or the exemptions we talked about. And the examples of decompensation include encephalopathy like confusion, ascites, and varices. We discussed that before. So we do all these appropriate workups. The only one that's not is not like it's appropriate to work something out with a stress test, but it's not something that you do as part of your general health maintenance. But basically everything else, most of these things should be done as your general health maintenance anyway. Kidney donors could be different ones. The best ones are the live donors. They work for the longest amount of time, the least amount of complication, need less medications. And this is how we divided these donors up. So when I get a phone call in the middle of the night, they say, okay, this is this kind of donor, that kind of donor. I'll explain. A standard criteria donor is a donor that's passed away who's age less than 50, right? And those donors are what we compare everything else to, right? They work fine. The problem is the wait time is between 4 and 6 years. Okay? And the problem with that is for everybody on the list, on the kidney transplant list, about 8 to 10% die each year waiting. And it does not include, obviously, the non patients who are removed from the list who become untransplantable. So because the wait time is so bad, and that has significant ramification in terms of morbidity and mortality, we've really pushed live donors, and we've had to push what's called extended criteria donors or expanded criteria donors. And that's any deceased donor age greater than 60 or deceased donor age greater than 50 that meets some standard medical criteria. We acknowledge that those kidneys do not work as well as standard donors, do not work as well as live donors, but for certain patients they are better than remaining on dialysis. For the most part, those certain patients are people who have an expectation of waiting a long time, usually more than 2 years or 3 years. If they are older than 40 and diabetic, or older than 50, period, right, they're thought to be benefited by extended criteria donors. These are donors after cardiac death. We discussed these before. These are people who have horrible prognosis, family wants to donate. They do not meet brain death criteria. They have to be procured in a certain different manner. Because of the low blood flow and low oxygen to the kidney, it kind of takes a hit, meaning that they have a high rate of delayed graft function. That means if you need dialysis after transplant, right, for a certain time until the kidney wakes up, right? But overall, the long-term survival is as good as a standard criteria kidney. Right? So we use a lot of these in this organization. We now use, or start to use more and more Center for Disease Control high-risk kidneys, right, or any organs. So Center for Disease Control identified a high risk. That's somebody, if you give blood, right, the person who paid for sex, had sex with somebody who paid for sex, male, all these things, hemophiliacs, people who receive many blood transfusions. Those people are high risk of transmission of disease. In the old days, and in some organ procurement organizations, we just turn that down, right? Here we use it. We've used a few lately. Actual IV drug abuse, present IV drug abuse donors. We ask the family, we ask the patient if he or she wants to use these organs. They're allowed to turn that organ down without any recrimination whatsoever, right? Frequently they say yes, because it was dialysis is shortening the lifespan and horribly impacting the quality of life. So they frequently say yes, and we use these donors. We have the expectation that it's safe for the recipient, although they're slightly higher risk. They are screened for HIV, although there might be a window where the HIV is not detectable, but it's still not be transmissible, and other things, and other diseases might be transmitted. However, and it's a recent article from Freeman as well, who came up with the MELT score, we compare the risks of waiting on the list for a perfect organ versus taking this high-risk donor. It's been clear that in his article that it's better to take this high-risk organ than to wait for it.
Now, before we move on, just out of curiosity, approximately, what would be the percentage of standard criteria donors versus extended criteria donors?
80 and 20.
80 standard, 20? And on the patient side, the waiting patient side, what's the ratio of people under 50 and over 50?
I don't know the number, but it's
Right.
aging. And it's definitely aging much more than before. So it used to be like 60 was the age cutoff for
Right.
liver transplantation. Now it's, I gotta say, it's in average age probably the 50s easily.
If you're going to cover this later, just move on, but I'm sure that had to be one of the major discussion points in recent years as we're trying to come up with a revised kidney allocation process.
I kind of talk about that, so there's two
Okay, good.
things we do now. There's the old for old, right, which is what they do in Europe. So you have an old kidney, right, and there's a list of old patients. So you have a 65-year-old donor, say, and, excuse me if I said old, in a nice way.
Hey, watch.
So we've done 65, and then it's available, right now, instead of running the whole list of 78,000 people, they just run the list of recipients who are, say, 60 and older, right? So that shortens that list. You make your phone call, see who's healthy, who's not, get that kidney procured and placed much quicker, right? And this is what they do in Europe, right? In Europe, and the results are good because they're cold ischemic time. Cold ischemic time is defined as the time where the organ is out of the body on ice before it's in the recipient. So that cold ischemic time is shortened, and hence results are better, right? And they're very happy. We essentially have a de facto old for old policy. You know, usually we won't give a 65-year-old kidney to a 25-year-old recipient because we know it's not benefited. Like I said before, we know people who are benefited by expanded criteria kidneys are age greater than 40 with diabetes or age greater than 50, period. Right? So generally we wouldn't go that crazy. But that would mean the opposite theoretically. If you have old for old, do you therefore put a 25-year-old donor into a 72-year-old recipient? So that's been an issue, and whether that's age discrimination or not. Also, this is kind of similar to this is one of the what people thought of as a potential new allocation scheme, which was quality of life years benefited. So the thinking was that, okay, here you got a 25-year-old donor, this probably should go to a 25-year-old recipient who has a certain disease process that won't recur, right, and they'll live longer so you get the biggest bang for your buck, right? But that might be age discriminatory. So that was one of the things that I mentioned later on. That was one of the things that was kind of brought up with shutdowns. Just too many variables has essentially been shut down as an allocation scheme. Here are other things. When recipients have hepatitis C or hepatitis B, they can safely receive an organ from a donor who was positive hepatitis C or hepatitis B. And I told you before, in the liver, in cases of extremis in the liver, we accept them even if they're not immune or have that diagnosis. Other, I forget. Other would be like maybe like the renal cell carcinoma, the kidney cancer in one kidney. Use the other one. There's been kidney transplants in the actual kidney had a kidney cancer, cut off and put it into the recipient. Wow. That's been done in the live donor scenario as well. In Japan, they've used kidneys. Say it's a 68. Usually, the reason why that happens is because we've learned that the renal cell cancer is kind of more slow-growing cancer than it was in the past, because it's being uncovered much earlier. Because of that, we can probably use the other kidney, use the liver, blah, blah, blah. But because of that, also, urologists have evolved to, instead of removing the whole kidney, to freezing, right? Freezing the kidney or burning the kidney. Like those programs like for liver tumors, we do the same thing, right? There are certain subset of patients who don't necessarily want that. They want the whole thing removed. So in Japan, they wrote an article on those patients who either remove the kidney, instead of just throwing it away, remove the kidney, cut that piece of cancer out, and use that. Those are things that we've had to do, right? Well, there are other examples, like I said, somebody who had cancer, a donor had cancer in the past, the drug abusing, all those other things. Infant donor kidneys, right? So it used to be thought that an infant donor, the kidney would be too small to supply good function to the recipient, right? That's probably not true. But there is some controversy whether the infant kidneys should be transplanted en bloc together or separated, depending on the size. Probably, the answer probably is, for that recipient, to have both kidneys is probably better. However, as a transplant community, to help more people, to separate them and transplant two people, even though the results might be a little bit worse, is probably what's best for the entire community. Right? So that's kind of the evolution we've had to make. We also, at Einstein and other places, we frequently do dual kidney transplantation. It's taking two kidneys from one deceased donor, usually an elderly donor that's probably not good enough by itself, and putting them both in one recipient, right? That provides them with more nephron mass. We get really good results. And that's usually a transplant that's performed in lieu of those organs being thrown away. Because nobody feels comfortable using one by itself. We use two. We got somebody transplanted, usually with very good results and no organ wastage. And the donor families are clearly then happy as well. Same thing, so here's a live donor. Live donors for livers, you talked about before with Prometheus, liver going back. There's been at least two donor deaths. Been at least two donor deaths. It leaves people a little bit ill at ease. There's been some morbidity associated with live donation. There is a significant learning curve, and there's some indications that need to be kind of straightened out, whether it's appropriate or not. Right, so it's somewhat controversial. We don't have the cardiac death, we discussed that before. That low blood flow, that low oxygen to the liver makes it more susceptible to hepatic artery complications and to bile duct complications. And then we discussed these. So here's all the risks of bad things can happen. And so we know that we wouldn't be doing this if it hasn't been established scientifically that this is beneficial compared to remaining on dialysis or compared to not being transplanted at all, or compared to remaining on dialysis with type 1 diabetes. These are some of the kind of things that have evolved. Status 7 means that, for a kidney transplant, status 7 means you're on the list, but since you're on the list, but since the organ allocation is driven by how long you're on the list, it used to be that you would lose your time, you wouldn't gain any more time. And now you can be placed on status 7. Let's say you're a kidney transplant patient, you're on the list, and you need your gallbladder taken out. Put you on hold for 2 months, right? You won't get any offers, but you won't lose those 2 months, right? So that's what we do. And that what frequently also happens is the patient accrues time as well while they're doing all these testing and things. Let's say a person gets a stress test that may or may not be positive or negative, they may or may not get a cath, may keep on going, blah, blah, blah. They don't lose time, right, on the list while they go through all these different things which turn out to be normal or fixable. We have to do that because it's a 5-year, 6-year wait time. So to have somebody wait 5 or 6 years and wait the other 6 months on top of that for the workup and things like that, we believe it's not appropriate. This thing, there's a potential. I don't know what this is. There's a potential. We talk about quality of life as being years added or whatever. There might be a chance of switching the time starts the clock starts ticking to the initiation of dialysis, right? So you have these poor Slavs who are poor people who are out, who have been on dialysis for 3 years, and maybe they weren't told clearly by the social worker or somebody else that they should have been evaluated for kidney transplant, right? Or who knows what may have happened. They didn't have insurance, all of those things. And then they come, they get worked up, right? And then they start the clock ticking. Meanwhile, they lost those 3 years. And those 3 years on dialysis are shortening their lifespan, right? So that might be one of the things that we think. Now, the contrary to that is we might be rewarding somebody who was told to go to a transplant center, didn't go, didn't have his act together, right? Then he jumps ahead of somebody who did it right away. So like everything, there's always, 2 sides. We also, and then I said before, remember the MEL scores which drives allocation, but it's time dependent for various exemptions. This is also new or newly enforced, is that the patients need to be told of all of their changes in status. So if they're moved from active to status 7 to active, off the list, all those things. So unfortunately, it happens much less now. But unfortunately, you see a patient and he goes, I'm on the list, right? Are you sure you're on the list? Yeah, I'm positive. Do you go and you get a workup done? Did you get anything? I'm not sure. I got a chest x-ray. Did you get a letter that said you were on the list, right? And then when they say, yes, I got a letter that said it, then I'm okay. But then they say, I don't remember any letter, right? That kind of thing. So that's, at least it's one way we can kind of track, but unfortunately, it's way too common that patients think they're on the list and they're not really on the list.
12 years ago, I received my kidney pancreas before I was on kidney dialysis. And I was literally day to day, how are you feeling? Would that not be possible now? Are you
It would be very difficult. It would be optimal. It would be the best if you could do that. But that's what I meant to say when I was when I was thinking about the status 7. It would be great. So kidney transplantation is best either preemptively or within 6 months of the initiation of dialysis.
But can you even get it anymore?
No, very rare. I mean, as a live donor, you can, right?
Yeah.
But very, very rare. I mean, wait time's 5 or 6 years. Every blue moon we come across, somebody maybe was hepatitis C patient, they don't have a lot of wait time, right? So either just before they go on dialysis, or their other kidneys failing just before they go on dialysis, we did that last week, right? So usually it has to be a very unique circumstance. Hepatitis C with a blood group AB, those people get transplanted very quickly, but ordinarily not. And it used to be thought that, or it used to be the situation that kidney pancreas recipients had to wait a very short time. Now they're starting to wait 2 years, 3 years, and things like that. And a type 1 diabetic on dialysis is a very bad combination. So that's going to be a bad thing that we're going to have to address. When I mentioned status 7 for kidney transplant, usually most commonly status 7 is reserved for kidney transplant or utilized a kidney transplant recipient early on, right, when they're about to be worked up or all that stuff. In the type 1 diabetic who's waiting for a kidney pancreas, usually it's after they've been on the list already for a year. So my translation of that is, they're already on the list, they've already been worked up, and something happened that made them sick, and they had to be removed, right? Whereas a type 1 diabetic is different than a type 2 diabetic, you know, that kind of thing. So we're gonna have issues coming in the future as our wait time increases, right? More people will be dying on the list, and also people will be doing less well with kidney pancreas transplant compared to how you do because of wait time.
I waited 2 years. I waited 2 years.
So you don't have
12 years of
years
that.
yet.
Right.
Right, so they can wait for a really good organ to get that.
What about multiple listings? Can you do that?
Yes. So is now a UNOS mandate that every patient be informed that they can list both multiply within an organ procurement organization and also in different organ procurement organizations. That's what Steve Jobs was able to do, right?
Yeah.
So that's about 5% of all the people multiple list, right? The downside is that who can double list people who afford it. People who have money can go drive around, fly around, all that stuff. The upside is that it might even out the organ disparity, right? If you have 10 years to wait in California, but 6 years to wait in Arizona, and that might shift things, then make things worse for people in Arizona. But yes, in New York, you cannot list, the state law, you cannot list within that organ procurement organization. Somehow they're exempt, right? But every other one, so you can list theoretically Einstein, Jeff, Penn, all that stuff. Really would benefit you so much, probably, because that organ will be offered via the organ procurement organization. So when the benefit is had when you list in Philadelphia, right? We list in Orlando, right? Because the wait time is shorter than in Boston, right? So then you can go fly down, get the kidney, that kind of stuff. And if you were in Boston, if you were only in Boston's organ procurement organization, you wouldn't even see that offer. But if you're listed in both, then you increase your chances of getting offer.
What you just said is interesting because I've always heard just the opposite as far as double listing within the same region. What would be the benefit then? I mean, you're right, the offer comes...
Criteria.
I'm sorry?
Criteria. You might you may be able to take advantage of a criteria at one transplant center that maybe you're excluded from another transplant center.
So you wouldn't list for both of them then? Because you would be excluded from one.
But that'd be one. Just say, what happens is when we have an expanded criteria kidney,
Yeah.
usually. So if you have a standard criteria kidney, it goes to, we have a standard criteria kidney is a list that you follow. Boom, boom,
Right.
boom. So you can't jump, can't do anything.
Right.
When you have an expanded criteria kidney or one of these high CDC risk kind of thing, right? Maybe an Einstein, right?
Okay.
We would use a drug abusing person and
Right.
maybe somewhere else they wouldn't.
I got
Right?
you, okay.
That kind of thing.
That makes sense.
And it may vary based on who's taking the phone call, who's doing that kind of stuff.
Or the criteria for the recipient also. You don't have an age cutoff. for
I
Einstein.
could see where
Yeah.
a recipient wouldn't be acceptable to most programs, but would be another one. That makes sense. But not double listing is different. One thing I'd just like to add, just because it's so trivial, okay? That last bullet, currently I'm serving on the Patient Affairs Committee of UMOS. They are revising the letter, the one-page letter that goes out to patients in this situation. Any change, you get this letter. That is probably going to be a 2-year process of changing that letter that already exists. We're not changing the rules, changing the wording in the letter. Nothing significant from my perspective, I gotta say, but it's just amazing. And I want to say that just because it's that careful down at that level, you can imagine how careful it is up when you're changing rules for allocation, which is what you're talking about. It's just amazing to see that. That's how careful it all is.
Here about the multiple listing we discussed. So it's also popular to do for liver as well because some OBOs transplant at a lower melt.
And the other point is, if all this information is available to anybody on the web, you go on the UMOS website. So this is not some secret the doctor knows. You can go do that research.
Patients have to be informed, they have the
Right.
opportunity to multiply list. Here's how kidneys are usually allocated. If there's a perfect genetic match, it takes precedence. Children take precedence. The liver kidney, heart kidney, they take precedence over kidney alone. Patients who have high immune reactivity, they take precedence, and then how much time you're on the list. And also, in here also is somebody who's a previous donor, right? Previous kidney donor, original renal failure, they go right to the top of the list. Liver exemption, liver allocation, we discussed this before, the meld and meld exemption. Okay, so here the kidney offer is called. The surgeon is asked generally if it's a good kidney, if he thinks it's a good kidney, he or she thinks it's a good kidney. You talk, once you find an appropriate recipient, the workup's up to date, everything's been good, patient is called, and make sure that the patient is healthy, like they're not recently hospitalized or having some problem, and does the patient want this organ, and then should there a backup be called in if there's any issues. Liver offer, same thing, basically. Kidney transplant take about 2 to 4 hours, liver transplant 6 to 8 hours. Kidney transplant recipients usually stay in the hospital about 4 to 7 days. Liver about 10 to 14 days. And then a lot of times kidneys, at least in our because we have a lot of African Americans and Hispanics, have a lot of diabetes after transplant, that this teaching has to be done. Same thing with liver. Our liver patients tend to go, we have a Moss rehab, we have a rehab facility, which we're open now, rehab facilities right next door. Our patients tend to go there after transplant. This is an issue, right, obviously, right, we'll start with freedom first. That's in both kidney and liver. Liver is more immune tolerant, so you can have less immune suppression, and you probably want to have as little as possible, so you can combat possible hepatitis C recurrence. So that's gaining speed. Probably about 80% of liver transplant recipients are eventually steroid-free. Probably about 30 to 35% of kidney transplant recipients are eventually steroid-free. And the other issue is generics. Prograf is now gone generic in 2008. Cellsat went generic. I guess Rapidine is going to have its competitor with everolimus and other generics. So those are issues that are coming up. And a lot of these things, in my opinion, have not kind of being mandated by insurance and pharmacies and things like that. The studies are pending or not being completely made. There's some question of whether it's completely appropriate.
And just out of curiosity, and the reason I raised the question is just the other day, somebody in an email list was looking for his information. His program, it had to be a heart program, precludes him from using generics for the first year. It caught me by surprise.
His program means the transplant program?
Transplant program, so he was up against it financially, pay for the program, and he wasn't able to use the generics for the first year. He's 9 months after his transplant. He's looking for some solution because he can't afford his meds.
That's exactly the scary now, so he's in trouble financially, yet the transplant center wants to make sure everything's as stable as possible for him.
Is that your policy, or is that a
No,
general
policy,
thing yet?
it sounds like a good one.
Yeah, okay.
Right, it's nerve-wracking, right, because we don't know what, so people, I don't want to use the word cavalier, or less stressed maybe, because we have levels, right, for programs, right? As opposed to switching from cell set to generics or things like that. However, we don't necessarily know what those generic levels mean, right? We don't know, right? So it's pretty scary with our government oversight, with our malpractice area here, to just switch like that. It's pretty scary for us. So to go to the years is a pretty reasonable idea.
Several months ago, I wound up in a situation where my insurance company, when I went to pick up my medication, the pharmacy said your insurance company ordered the generic version of Cellset as opposed to Cellset. And I took it. And after about a week, there was a noticeable reaction. I felt like I had gone back to square one in terms of my hands shaking and just not feeling right. My transplant team intervened. The insurance company put me back on Cellset. I mean, I don't know if there's any studies or anything that determine this, but as the patient, I can tell you that almost immediately after a day or two, I felt very different.
I just came back from Puerto Rico. There's some stories. There's some letters to the editor kind of things in our journals. I'm thinking of one patient right away who, when he was switched, he believes that it was associated with the rejection that he had. I don't know how, I can't speak to the science or non-science of it. It just has not been shown consistently, I don't think. Right, so I don't know the answer, because I don't know the answer. It's just scary for us. Right? We're on the same page, but obviously we want you to do well. We want, and adding this uncertainty is nerve-wracking. Here's all the old flow. Here's this is I guess I didn't know where I was going to put this in, but this is a transplant, an example of transplant tourism theoretically, right? So a poor guy undergoes open nephrectomy, his post-laparoscopic nephrectomy, donates his kidney, and it's been shown, different things have been shown, right? In Iran, they showed that they eradicated the kidney transplant waiting list, right, with paid donors, right? But in other areas, other poor countries, it's been shown that they get paid, and then 2 years later, they're back to the same level of poverty where they were before. And also, we found also with transplant tourism, that people are now coming back to the States with diseases that are acquired, that they weren't really screened for in these other nations.
Do you accept patients who come back with a
Yes. We
transplant from another country?
It's our responsibility, yes.
Okay.
This is an incision here. Here's a kidney. Here's this is a live donor kidney. This is the artery, and that's the vein, with the ureter. This is a kidney that has come from a it's a deceased donor that was transported in the bag, and then you just ice on it, that cold ischemic time, right? So we just a little thing, a little interesting thing. We take this vessel. This is what we do lately at Einstein. Here and here, we take that vessel, those vessels, and we like punch a hole through there, say, right? While there's still ice in here, we clean it up, we've done preparation, put it back in the bag with ice, punch a hole through, pass through the artery, the vein, and then sew the kidney in to the recipient while it's still in the bag, right? We believe that that's avoiding warm ischemic time. So we have cold ischemic time is when the organ's out on ice before it comes out. Warm ischemic time is the time it takes to sew it in, right? That it's getting warm, the liver, the kidney, the heart, all
What's the word after cold or warm?
Ischemic.
Okay.
That's ischemia when the cell is presumably dying, right? So we are hopeful that that by eliminating warm ischemic time, we might be improving graft function, we might be decreasing delayed graft function, or at least the length of time for delayed graft function. We've done about 30 cases so far. It also allows for calm placement of all the sutures and things like that. We think better technical results. So we'll see. Hopefully, we'll do about 75 more, and we'll see what happens. This is a kidney, the vein, the artery. The artery being sewn in, and the vein is sewn in. Kidney. It's the liver. On the back table, I'll show you. Here's the liver being sewn in. Here's the right lobe of the liver, the left lobe, left lateral segment. This is a clamp on the inferior vena cava. The liver is now out. It's a big empty space there now. Here's the liver being in the process of being split. Here's an incision. We usually make an incision like this, or an incision like this with a little extension. This is a liver transplant called Mercedes-Benz. Sometimes we use an incision that goes like that. Make it bigger. Here's a liver being removed. Here's a cirrhotic liver being removed. And that's it. Any questions?
Where do you mostly connect the kidneys now?
The kidneys are connected usually to the blood vessels, the iliac artery and vein. The pancreas usually to the iliac artery and vein, but sometimes the pancreas can connect to the artery via a long graft, long conduit, and then connected to the portal vein. Some people do that because it's supposed to be more physiological. It's how the natural pancreas is, right? And then the pancreas has two jobs, right? It's the endocrine function of correcting blood sugars, and it's the exocrine function of digestion, right? When we transplant that, we don't care about the exocrine function, right? If those juices get made and have to be released somehow, about a third of the time people put it directly into the bladder, right? And then most of the time now, 70% of the time, we can make that connection directly to the intestine. Anything else? Thank you.
Thank you very much.